All right, so good morning, everyone. So today we will continue with part two of the endocrine system. And in part two, we will cover two main glands, the pancreas, which is the diabetes, both types, type 1 and type 2, and then the adrenal glands, adrenal Cushing syndrome, Addison's disease, pheochromocytoma. So what do we know about the diabetes from other courses?
It's a failure of the pancreas to provide enough insulin.
Good. So that's there is a dysfunction in the pancreas to produce a sufficient amount of insulin. Okay, so that would be some, or unable to produce any insulin, right? So we classify diabetes also as a multifactorial disease, which means that it's not just the insulin or the pancreas problem, and we have specific cells in the pancreas called the islets of Langerhans, and these cells produce the insulin, and they are the only cells that are, in which the genes are. We said we covered that under the genetic chapter. We said the gene is expressed. The only gene to produce or to give orders to the cells to produce the insulin is the available in the pancreas. Even though we have also cells that are able to produce the insulin, but the gene is not expressed. So that's said about the under the genetics and genomics chapter. So back to the diabetes, we said diabetes is a multifactorial disease. So it starts beginning with the pancreas as the main organ that is responsible to produce or in producing the insulin. But there are also other factors that will come into play to, give us that disease, like genetics, family history, right, and other sedentary lifestyle, overweight, obesity, and all of these. There's a lot of factors that kind of work together to produce or would result in the disease that called diabetes mellitus. So the difference between type 1 and type 2, given your experience with clinical or from maybe having patients or knowing people with diabetes type 1 or type 2?
Isn't type 1 the body doesn't produce insulin at all, whereas type 2 the body stops producing insulin?
Yeah. So with type 1, it's usually it's diagnosed at early age, like children born with, or they will develop that at early age and stage, and that's when the pancreas is unable to produce any insulin, and that will be because this is the old outdated now term, or the name of the disease we used to call it the insulin dependent diabetes mellitus, but now it's type 1. For one of the reasons that not necessarily just type 1 who should will receive the insulin, but also be type 2 will be also receiving insulin. So it's called type 1, and type 2, it was used to be called a non-insulin dependent diabetes mellitus, but now it's called type 2. So these are the correct names, is type 1 and type 2. We'll go over that pathophysiology and some of the symptomatology and differences between type 1 and type 2. In the complete absence of insulin, type 1 patients, they tend to develop what is called a DKA, diabetes ketoacidosis. And nowadays you hear about the keto diet, right? The keto diet, which is the production of ketone bodies, but that's a little different. That's a different story because the ketone bodies, that's a healthy kind of status, even though it's a harsh kind of program, like kind of fasting program, which is your body's going to lean to use the ketones as a source of energy. So that's kind of the whole principle or basis for for the dieting based on keto, is that your body's going to be fasting and then will be leaning towards using these ketone bodies. However, in patients with diabetes type 1, they have no insulin, and all what they can, the body can, can lean to or use is these ketone bodies. And these ketone bodies are acidotic, and they will result in acidosis. So they tend to develop what is called the metabolic acidosis. So patients with type 1, they develop diabetes ketoacidosis because there is no insulin. So the body, the only available thing to, or food product to use as a source of energy is to lean for these fat molecules. It will use the fat molecules. The byproduct of using them as a source of energy would be the ketone bodies. And they are, detrimental to the point that they will result in diabetes ketoacidosis, and patients will be admitted to the ICU because of that. And then the other side, we have another kind of similar, scenario, but it's not DKA with type 2. It's called HHNKS, and we'll go over that. It's hyperosmolar, non-ketotic HHNKS, which is hyperosmolar, hyperglycemic, non-ketotic syndrome, which means hyperosmolar and then hyperglycemia, but non-ketotic, ketotic, which is no ketone bodies, no ketoses or ketone bodies. That's will be with happen to the patients with type 2, but they will be severely dehydrated, and it will result also in fluid and electrolyte imbalances. So this just briefly some differences between type 1 and type 2. But in general, the manifestations, the hallmark of diabetes will be polyuria, polydipsia, right? Polyuria and polydipsia. Okay, so let's move on and see. That's the difference between these are just it's kind of busy figure, but it gives you or provide you with causes and consequences of diabetes. What caused diabetes and what are the effects on other organs. This slide's provide with all the risk factors, which makes it the multifactorial disease, given the like the multiple factors that could result in diabetes, lifestyle, like obesity and lifestyle inactivity, hypertension, race, pregnancy. We'll talk about that, that gestational diabetes that affects pregnant women also. So that's another form or type of diabetes other than type 1 and type 2. There are one form of diabetes that affects the woman during pregnancy called gestational diabetes. We talk about the etiology, which is causes, and genetic or autoimmune, viral infections, environmental like stress, obesity, inactivity, physical inactivity. So that's the etiology: genetic, autoimmune, in which that antibodies will attack the pancreas and or special, the special cells, the cells in Langerhans, and destroy these cells responsible for production of the insulin. And then the viral infections, and under etiology can also the environmental like stress and obesity and physical inactivity. So the metabolism, this is one of the best analogies. I keep like teaching, whenever I teach about diabetes, I always refer to this analogy of the lock and key as a type for type 1 and type 2, that the glucose molecule supposed to enter the cell for metabolism. If it stays in the blood, in the plasma bloodstream, it will result in hyperglycemia. It has to enter the cell. And who would assess the cell to enter, assess the glucose molecule to enter the cell is the insulin. So we have a lock and key principle or phenomena. Insulin is the key that is going to open the door to and open that lock, which is the receptor, so that the glucose can pass through the door into the cell. Now, using this analogy in type 1, the key is, or has been stolen. There is no key, right? So key has been stolen, no key. So no insulin is going to make it to the, no insulin made by the pancreas, and no glucose molecule will make it into the cells. So all glucose molecules will stay outside, which is in the plasma, and patient will become hyperglycemic, and that is type 1 diabetes. Key is lost, stolen. Now, with the, again, just keep that, principle that the glucose molecule is supposed to enter the cell for metabolism, to be metabolized. It stays in the plasma, that's going to happen. Now, second, which is type 2, the door won't open, fully open, and that is the, what is called type 2, which is insulin resistance. So there is an insulin resistance. The door won't fully open, or open fully, or wide open. So then some glucose molecules will enter the cell, but the majority of the glucose molecule will stay in the plasma. And that is type 2. So this is one of the best analogies, just to remember type 1 and type 2, given the principle that the glucose molecule has to enter the cell for metabolism. The insulin, so this slide is very important because that provides all the functions of the insulin. Insulin is way beyond just the glucose metabolism. All of these are the functions of insulin, or the presence or the absence of insulin will result in these physiological processes. Like insulin, after the meal, it will stimulate storage of glucose as glycogen, which is called glycogenesis, which takes place in the liver. It will inhibit the breakdown of the tissue by inhibiting all the three mechanisms. And these three mechanisms, the glycogenolysis, or the gluconeogenesis, or the ketogenesis. Like, for example, ketogenesis, which is the conversion of fat into acids. In the absence of insulin, this is going to result, so first of all, will happen, which is the ketogenesis. The body will use the fat as a source of energy, and then eventually the patient will have a decay. So that's an example of how the insulin will inhibit the ketogenesis. It will inhibit the gluconeogenesis, which is the conversion of protein to glucose. But in the starvation, has to be done. That's one of the ways of the body is going to lead to its own protein as a source of energy. Glycogenolysis, which is the glycogen breakdown to glucose. Glycogen is stored in the liver. In the absence of insulin, that's going to happen, which is glycogen broken down into, and that will result in glucose hyperglycemia. So the insulin will prevent these three mechanisms from happening. The insulin also, it enhances the fat deposition in adipose tissue. Now, the hormones that work contrary to the insulin, anytime you hear glucagon, automatically will say it's going to result in hyperglycemia. Cortisol, hyperglycemia. Growth hormone, epinephrine. All these hormones are, so in the homeostasis kind of status, these hormones will be working against the insulin, or contrary to the insulin, opposite to the insulin function, to maintain the homeostasis and normal, or within range, normal glucose level in the plasma. Plasma glucose level will be maintained with the harmony and working together, the insulin and these hormones. So growth hormone, automatic elevated growth hormone, we will see that will result in hyperglycemia. Same thing with the rest of the hormones like glucagon or cortisol. And one can give me an example of steroids or cortisol, how it, or from maybe clinical application. If you have seen anything like that, which is like patients on steroid will be on insulin sliding scale coverage for that. That's would be some, in the mid-surge unit, some of the like frequent scenarios, patients never been diabetic, had never, no history of diabetes, never been diagnosed to be diabetic patients or with diabetes. And then all of a sudden, when they are admitted on steroid medication, especially IV steroids, corticosteroids, they will be put on sliding scale insulin coverage. Well, they have no history of diabetes. And they will come to ask, probably going to ask you as a student, how come, I have no diabetes, I'm not diabetic, and I'm on sliding scale insulin coverage. The answer would be is that because the cortisol, the steroid medication, the IV steroid, it results in hyperglycemia. And we have to control the resultant side effect by that coverage of insulin with insulin. Is this clear, this point? Because this is one of the most important concepts in mid-surge units when it comes to steroids and hyperglycemia. The patients constantly they come and ask, sometimes nurses, and they will come, again ask students, and that's something that you keep in mind when you go to the mid-surge unit, is that patients on steroids, they will be also on sliding scale coverage with insulin to counteract that side effect of these steroids. So type 1 and type 2, we said type 1, which is the used to be called, which is outdated names now, which is juvenile or IDDM, which is insulin dependent diabetes mellitus. These are the old terms or names for the, but it's only called type 1 diabetes mellitus. And we talk about the pathophysiology, why patients develop type 1. We said that that's due to the destruction of the islets or islet cells in the islets of Langerhans and the pancreas due to genetic susceptibility or immune disease or environmental factors. The autoimmune disease, the autoantibodies, they are result in the destruction of the beta cells in the Langerhans and the pancreas. And we said it's genetic predisposition in which that they found the human leukocyte antigen, which is HLA. Under the genetic predisposition, you can put that's related to the human leukocyte antigen. And that was located on chromosome number 6. And then the exposure to viruses like mumps or congenital rubella, and because they trigger the autoimmune destruction of pancreatic beta cells. Type 2, which accounts to the majority of almost 90% of all cases of diabetes. And out of that, about 80 to 90% of the cases of type 2, that's due to overweight. So the highest risk factor for type 2 is obesity and overweight. So the prevalence also will increase with age. The um, the, the onset of the disease, the pancreas continued to produce some endogenous insulin, a small amount, it's insufficient. So the insulin is two things. So we have two scenarios here. Either that the insulin is insufficient or the insulin is poorly utilized by the tissues, which is what we call insulin resistance. So either the insulin is insufficient or the insulin is poorly utilized by the cells or tissues, which is the insulin resistance. So two could be one of the two scenarios or both. That's for type 2 under the onset of the disease process. The factors, we can identify the factors earlier, and then the three times we said either the insulin resistance or something called impaired glucose tolerance or inappropriate glucose production by the liver. So three metabolic abnormalities that are can be listed under type 2. Like under tissue resistance, for example, the body tissues and cells do not respond to the insulin, resistant to the insulin. The receptors that are unresponsive, or we don't have enough receptors. Impaired glucose tolerance, that's when the alteration in beta cells is kind of mild. So there is impaired glucose tolerance. So the blood glucose is higher than normal, but it's not enough to diagnose patient with diabetes. So we call it IGT. Or we have a problem with the liver, so it's inappropriate glucose production by the liver. The gestational diabetes, which is the diabetes that affects the pregnant women. So I put here, enough information about the disease in terms of the prevalence and the the risk. Ethnic, or racial effect, who would be more affected by the disease, and also the percentage in terms of gender. Sorry about the percentage. The age groups. Sorry, the age groups. So this is just again the gestational diabetes, which will develop during pregnancy. Then it will be detected by or at the 24 up to 28 weeks of gestation, and increased risk for cesarean delivery, perinatal death, and neonatal complications. So it's associated with other problems, like there is a high risk for cesarean section or delivery, because the patient, the babies will be overweight babies, and also it's associated with perinatal death, which is death prior to delivery, and complications that would affect also the babies or the neonates. So the secondary diabetes, which will result due to other factors like the Cushing syndrome. Patients, we said, with Cushing syndrome, they will have an increased cortisol level. So they will develop hyperglycemia, hyperthyroidism, increased metabolism, result in hyperglycemia, and patients with the parenteral nutrition. And I believe in Adult Health 1, you go over this, the parenteral nutrition, TPN, right? The TPN and PPN. So because the nutritional supplement or the intravenous IV nutrition, which is the total parenteral or parenteral nutrition in general, it will have high glucose molecules. So the patients may tend to develop this secondary diabetes from that. Now the type 1 versus type 2, see type 1 patients tend to develop what is called ketoacidosis. But the there is some differences in terms of manifestations. Like type 1, it's class, it's classic symptoms of polyuria, polydipsia, polyphagia, weight loss, and then the type 1. And in type 2, not necessarily you will see these symptoms in type 2. Again, that's age. It's type 2. It's more due to the overweight, obesity, and then the lifestyle or inactivity, physical activity, and also with age. So the symptoms are quite different. Doesn't mean that the patient is not going to develop symptoms of type 1. They will develop, but not to the extent of type 1 diabetes manifestations. But in general, type 2 will develop the fatigue, general weakness. They will have problem if they develop a wound, that they will have a prolonged wound healing, delayed wound healing, infections like cellulitis and infections of lower extremities, especially visual changes as a long-term complication. So this slide provides the significant differences between type 1 and type 2. So you can read in your own. Now, diagnoses. This is very important about how to diagnose patients with diabetes in general. So we will go from the most important to the least, and how we're going to use these 4 factors. The first diagnostic tool or study would be the hemoglobin A1C. Hemoglobin A1C, which is, anyone have an idea what is hemoglobin A1C would be?
Yeah, but to detect sugar in our blood.
Yeah,
I'm sorry.
fasting will do the same thing, and random will do also detect the glucose in the blood too. But what's different about the hemoglobin A1C?
Doesn't it detect like what your blood sugar has been over a certain amount of time?
Right, exactly. The good thing about the hemoglobin A1C is that it's not the testing of the glucose molecules instantly. Right now, it's the plasma. Like fasting, you have to fast for like 8 hours to get the fasting glucose level, and then after you ingest it, then it's no longer valid. It becomes random. You will eat. You can randomly take it anytime, regardless of when you had breakfast or lunch, or you just randomly taking blood glucose. You do run the plasma glucose measurement or level. That's random. Fasting, you have to fast for 8 hours. For hemoglobin A1C, it's not just for what is the glucose molecule, glucose content or concentration right now in the blood. It will measure it over 120 days, which is the lifespan for the RBCs. It's how much glucose deposit on the red blood cells over time, which is the lifespan of the RBC. That is the hemoglobin A1C. So glucose remains attached to the hemoglobin molecule over 120 days, which is the lifespan of the RBC. Normally supposed to be between 4 to 6%. So the hemoglobin A1C is a great tool for diagnoses, to diagnose patients with pre-diabetes or with diabetes. And also it can give us an indication. We don't want to be judgmental with patients to say, oh, how come your A1C is 9 and now you are not taking your meds, you are not taking your you are not following the diet recommendations, you are not following the diet plan or the care plan. So we don't want to be judgmental to the point to say that, but it still it provides a significant amount of information about how the patient is behaving out on their own, like when they are going home, when they're going to nursing home, or we can tell if they are eating like within the plan or the dietary recommendations, if they are taking the meds or not taking the insulin. So we have an idea. It's I would say significant piece of information. But when it comes to patient communication or patient disclosure, we should be very careful not to be judgmental. But it will give us a great, again, this is one of the great tools or diagnostic studies to rely on as we measure the patient's compliance with the what is called self-management. So it's the self-managed, the disease is chronic disease. Most of the time, patient will be on their own self-manage their own disease. So the A1C supposed to be between 4 to 6. It is become diagnostic. Diagnostic. I put here when the because a little confused, sometimes very confusing to for these numbers as you review them from the book. But I put them both numbers. When it's diagnostic, it will be any number equal to or above 6.5, and then 5.7 to 6.4. We can say that the person would be at risk for diabetes. So this is I provide all the numbers for fasting and for random. So you will go for the first one. You say or fasting over 126 or random over 200. And random usually it's done after the patient ingests like the 75 grams of glucose, and the lab, this is done in the lab, and then after they take the 75 grams of glucose, and then we measure it, and that's the OGTT, that's oral glucose tolerance test, oral glucose tolerance test, and any number over 200 or 200 or above, that's diagnostic. Now so in the absence of the unequivocal hyperglycemia, criteria 1 through 3 diagnosis requires 2 abnormal test results. So you need 2 test results to diagnose. So I'm not going to to highlight, go in depth in terms of how would you diagnose, how do you use these these diagnostic studies to diagnose patients with with the diabetes, but at least just we rely on these 4 measures to diagnose patients with diabetes. And sometimes we have to do it like twice to confirm the diagnosis. And the most important aspect of all of this is the manifestations, the signs and symptoms. So we have to associate these results with the patient's manifestations and clinical picture of the patient. I just included these informational. You gonna keep this, this. You're not going to be asked questions about this is pharmacology. And it's just give you the different, will help you with adult health 1 and also with the pharmacology class next fall. So this is just informational. So you will keep it, use it, whatever, it's just information. I'm not going to ask you about the types of insulin and the, the onset or when is the, it's going to peak and how to use it, or even the implications of insulin therapy, or insulin injections. But there are complications from insulin. I'm sorry, so again, insulin, that's pharmacology stuff. I'll leave it for the other classes. Let's talk about the complications from diabetes, type 1 or type 2. So the complications, the first one would be the hypoglycemia. And which is the blood sugar less than 70. The treatment would be that patient's blood sugar less than 70, you will follow the protocol in the healthcare institution. Every hospital, they have their own protocol about the hypoglycemia glycemia protocol, how to, nurses and professionals would, and clinicians would react and intervene in case the patient develop hypoglycemic event, because that could result in hypoglycemic shock. And this will be part of the adult health 2 mid-surge class, how to treat patients or treat cases, scenarios when the patient develop the hypoglycemic event. Now, another complication, and this is an acute complication, and because we have also chronic complications or long-term complications. So the acute one could be also the patient develop a DKA, which is most likely going to be affecting patients of type 1 diabetes type 1, and then the HHNKS, which is hyperosmolar hyperglycemic non-ketotic syndrome, which is no ketone bodies in this complication. So this complication, HHNKS, doesn't include the mechanism or the disease process or the stages of the complication does not include any ketone bodies, but it will be part of the DKA. That's why patients in DKA will become acidotic, and patients with HHNKS, which affect HHNKS, affects patients with diabetes type 2, they will be severely dehydrated. And that's the hallmark of the HHNKS, the dehydration, aside from the hyperglycemia. We'll go briefly over the difference between the DKA and the HHNKS. So the DKA, briefly went over this at the outset of the lecture, and said that the patients, they don't have enough insulin, so the body is going to lean to what is called the gluconeogenesis, which is the use of the use of fat. I'm sorry. It's not the gluconeogenesis. The insulin deficiency causes the gluconeogenesis, which is the production of glucose from protein. And the DKA, the body is going to lean to use the fat molecules as a source of energy. And the byproduct of the fat molecules and the absence of insulin, will result in the metabolism of the fat molecules will result in the ketone bodies. And that's why the patient developed that DKA. So the patients will, in that, due to the acidosis, remember that the acidosis we have, this is metabolic, then the lungs supposed to breathe faster, right? To blow off the CO2. So it will reach the homeostasis and decrease and fix the pH, right? By blowing off that CO2. So then the patient will develop something called cosmorespirations. So this cosmorespiration is a compensatory mechanism to fix the acidosis. Patient also will have a fruity, kind of sweet breath odor, and that's from the acetone bodies. And patient also will become dehydrated with acidosis and electrolyte imbalances. Remember that acidosis patient will be hyperkalemic. So we have to fix the acidosis and the hyperkalemia. These are some of the factors that would precipitate the DKA. Patient is not taking enough insulin, is not managing their own disease in the right way or according to the protocol, according to the plan of care. Could be neglect, which mostly going to affect the older adult in long-term facility or a home setting, but that could be neglect. So the treatment and the management, that's going to be part of the adult health too. So we're not going to focus on that. It's just the pathophysiology and the precipitating factors that could lead to a DKA. And now we have this slide differentiate between the DKA and the hyperosmolar hyperglycemic non-ketotic syndrome. So DKA, it doesn't mean that patients with DKA they will have even higher glucose level. Any a type 1 patient or diabetes type 1 patients with diabetes type 1, any glucose, serum glucose level over 300, they may develop DKA. But for on the other side, diabetes type 2 patients won't develop that HHNKS until that glucose level goes up to like a 600 or 700 or 800. I have seen patients with glucose level of 12 and 1300. So these are some of the differences between in terms of the assessment as you assess the patient, but you can tell that the cosmal respirations is not present in HHNKS, only present in DKA. You can tell that there is profound dehydration. There is some dehydration in DKA, but it's not profound like HHNKS. The HHNKS, because it's hyperosmolar. Hyperosmolar results in severe dehydration. Chronic complications, which includes the macrovascular and the microvascular. There are too many mechanisms that would result in the changes in the vasculature, blood vessels, and eventually will result in the complications of either macrovascular or microvascular. The macrovascular, like the coronary arteries, just it has to do with the changes in the walls of the blood vessels due to the hyperglycemia. Heart, brain, peripheral. So coronary artery disease, cerebrovascular accident, which is a stroke, and peripheral vascular disease. The microvascular, which affects the small, tiny vasculature, which is the capillaries and the small blood vessels, and these three organs, the retina. So that's why patients with diabetes supposed to go for ophthalmic and eye exam, right? At least annual, and follow up with that. Nephropathy, diabetes will do or result in some changes in the nephrons and the blood vessels, the structure of the blood vessels and the perfusion to blood vessels of the nephrons. That's why the kidneys will be affected, and then the neuropathy. And you surely heard that from patients who have the neuropathic pain, right, in their periphery. This change is expected also in the skin as neuropathic changes. So these are that's the difference between macrovascular and microvascular. The macrovascular. So again, there are many mechanisms that would explain why patients develop these macro and microvascular. So the macrovascular, the degree of vascular damage that is usually related to the duration of diabetes and not the severity of diabetes, the duration. So the longer the patient, live with diabetes, that would result in high likelihood or increased risk for vascular damage and resultant macrovascular disease. So it's not about the hyperglycemia itself, but it's the duration. The degree of the vascular damage is related to the duration of the diabetes and not the severity of diabetes. So the complications we said could be like in the patient would develop ECVA or coronary artery disease, CAD, or a PVD, peripheral vascular disease, which affects the lower extremities, the perfusion to the lower extremities, and the patient will have something called intermittent claudication, which is the pain in the lower extremities as they walk, because they have decreased perfusion in lower extremities. So when they walk, then they will experience severe pain at the lower extremities, and then they will stop. There is no walking, they have severe pain, then they will stop. So that's why we call that intermittent claudication. We'll cover this under the vascular disease or cardiovascular disease system, the PVD and PAD. the micro angiopathy, which is the effect on the, or a complication that will affect the eyes or retina due to the disease of the small blood vessels in the eye, especially the retina. So retinopathy, nephropathy, and dermopathy, which is you can call it neuropathy, or dermopathy, which is specific to the skin. These are the three common micro angiopathies or microvascular complications. Kidneys also will be affected. And there's a chart here that will walk you through the consequences or the disease process from the chronic hyperglycemia down how the GFR will be affected, glomerular filtration rate, the GFR, which is the creatinine clearance, you can call it too, as it's very equivalent to the creatinine clearance, GFR. It will be significantly affected by the hyperglycemia and decreased. Neuropathy, and that explains patients with with diabetes. They tend to have wounds in lower extremities and cellulitis and infections and infected wounds and non-healing wounds or wounds that are difficult to be healed, delayed wound healing. All of these are that known for patients with the diabetes, and part of that is the neuropathy. And sometimes patients with diabetes, so foot care is one of the significant aspects of the management for diabetes or patients with diabetes. And also, about the foot care, sometimes patients, they use a heating pad or heating applications because they have a limited or diminished sensation. So that's would result in burning the skin, and that is a complication, which is now we have skin breakdown, burning, wounds, and then difficult to heal or delayed wound healing. So that's one of the problems with sensation or the neuropathy, how it could tend and end up with complications like burning and skin breakdown and so forth. So the infection, patients always tend to develop the infections, cellulitis and infections. And that's because of these 5 factors. The senses, because there's impaired vision and touch, both will diminish the prevention of breaks in the skin because they have no warning sign. The warning sign is that when you feel something hot, you will avoid it, but they don't have that, so they kind of lost that the sensory and the visual. So they have impaired vision and touch. Both will diminish the prevention of the breaks in the skin because they have lost these 2 senses. The hypoxia, due to the compromised skin integrity and the hemoglobin A1C, and that will impede the release of oxygen to the tissues. The pathogens, they proliferate rapidly in any fluid with high glucose content as a source of energy. Blood supply decreased. It will be decreased from vascular changes and decreases the supply to the white blood cells to the affected area. The white cells, they suffer impaired function. And there are different mechanisms how that, like the chemotaxis and the phagocytosis, that's related to the white blood cells. So that's for diabetes. Any question about diabetes? So the next section of the today's class is the adrenal glands, and this covers 3 disease processes. The first one is Cushing syndrome, and the second is Edison's disease, and then the third one is pheochromocytoma. But most of our discussion will be covering the Cushing syndrome and the Edison's disease. So first of all, that's, begins with the function of these hormones. So first of all, we have two, the anatomy of the adrenal glands. First, both glands are located on the top of each of both kidneys. So we have right adrenal gland on the top of the right kidney, and the left adrenal gland on the top of the left kidney. Now, each gland is composed of what is called the cortex and the medulla. Medulla produces hormones, and cortex produces also hormones. So these are the diseases, and then the adrenal gland. So adrenal gland, the hormones are secreted from the adrenal glands. We said the adrenal medulla produces some hormones like dopamine, norepinephrine, which is the adrenaline, and the epinephrine. So epi and norepi and dopamine, they are coming from the medulla, the inner core or tissue of the adrenal gland, but the cortex, the outer aspect or layer of the gland, produces the significant important hormones. Now, why the absence of the adrenal gland, medulla, it doesn't, so if the medulla doesn't produce enough dopamine or norepi or epi, it doesn't upset the maintenance of the homeostasis. It doesn't have like significant, effect on the homeostasis because there are other cells. Cells and tissues in the body produce these hormones. There are too many cells in our body that produce these hormones, dopamine and norepinephrine, epi. And you recall that, do you remember dopamine and the Parkinson's disease? How is the dopamine? There are cells, right, and the brain can produce, right, these. So we have other cells in the body and tissues able to produce these hormones. That's why the absence of the adrenal medulla and its hormones, it doesn't upset the maintenance of homeostasis. However, any changes in the cortex production of cortisol or aldosterone is significant, is going to result in manifestations and disease process, or disease. Androgens, not that much, because we know the androgens also are produced by other organs and other cells. So let's focus on the cortisol, on the aldosterone. So the function of, endocrine system is very important that we always begin with the function of the hormone to be able to predict the changes or the mechanism or the pathophysiology that would result from the increase or decrease of this hormone production. So the cortisol, it's significant hormone because it does all of these things. Metabolism of the carbs, protein, fat. Stress related also, or response to stress, is affected by the cortisol. Emotional stability. What else would be also a significant function of the cortisol or steroid? Here in the body, we call it cortisol, because that's the natural intrinsic hormone produced by the adrenal gland cortex. But exogenous, synthetic, or exogenous like medication is the steroid. It's like dexamethasone, for example, solicordiv, methylprednisolone, right? Decadrone. These are steroids, medications. But here we talk about the hormone, the endogenous natural hormone. So what else would be included under the functions of the cortisol?
Stress.
Right, we mentioned that on
Oh,
number 2. Yeah. Yeah. Like patients who take steroids, for example, what would be affected significantly? One of the systems, they will be tempted to or predisposed or at risk to develop infections.
It's the
So-
inflammation?
Immune system.
Yeah, anti-immune.
Yeah, it's an anti-inflammatory, a drug. It's the drug of, I call it the magic drug. It's a magic drug. You can treat almost like, I would say any disease, because you're not treating the disease. You are treating the symptoms and manifestations of the disease. Any disease process include inflammation. But right away, that steroid is going to take care of all the signs and symptoms of inflammation, pain, redness, swelling, all, any pressure on the nerves, and all of these manifestations will be resolved by steroid. That's why it's a magic drug. You can treat, so it doesn't treat the disease. It will take care of the symptoms and manifestations of the disease. However, the side effects associated with the steroids also, it's massive. It's a lot of side effects that will be, you can list like hundreds of side effects that belong to that steroid or from the long-term use of steroid. If you prescribe it for a short period, and you taper it off, that's not going to be a problem. But long-term use of steroid, high doses, that would result in what is called the Cushing syndrome and its associated manifestations. And would just highlight some of these manifestations because you can take this when we discuss the Cushing syndrome. Hyperglycemia. So anyone who takes the steroid intravenous, even short term, they will develop, hyperglycemia. But on long term, I will include short and long term, but these are with side effects of steroids. Hyperglycemia, osteoporosis, GI ulcers, like peptic ulcer disease or GI, ulcerations, hypertension, fluid overload, weight gain, delayed wound healing, immunosuppression. So this is just some of the long list of side effects for us, for the steroid. It's a magic drug. Again, it takes care of all the signs and manifestations of the inflammatory process and inflammation. And that's why you will see significant improvement on symptoms like pain and and all the symptoms that are associated with the inflammation, edema, swelling, redness, all of that will be resolved, but it doesn't take care of the underlying cause. The disease itself, it's still there. It doesn't treat it. It will, sometimes we prescribe it for patients with a post or status post the transplantation organ, kidney transplantation or any type of transplantation, then we will prescribe that long-term therapy. Patients should be on steroid for a long, in addition to other immunosuppressive agents, because we want to prevent the organ rejection. Another hormone produced by the cortex is the aldosterone, and we said that the function of the aldosterone is fluid electrolyte balance, mainly. Remember, because the cortisol, it's two sections or two components. We have corticosteroid hormone, which is the steroid cortisol. I'm sorry, the glucocorticoid, which is the steroid, and the mineralocorticoid, which is the aldosterone. So hormone controls the, which is the cortisol, controls most of the glucose and other functions, has other functions. And the mineralocorticoid, which is the aldosterone, controls the fluid electrolyte. So fluid electrolyte mainly would be the potassium, sodium effect. So the aldosterone will retain sodium and excrete potassium. So the higher the aldosterone, more sodium will be retained and more potassium will be excreted as like it's removed by the, with urine. So patients with high aldosterone will be hypernatremic and hypokalemic. And eventually, because of the hypernatremia, the fluid also will be retained as well. So they would have fluid overload from the increased aldosterone. So knowing the function is very important to know the functions, because you can predict and you can anticipate and understand the manifestations for for the disease process, for both for Cushing syndrome and for Edison's disease. So Cushing syndrome, due to the high cortisol, we talk about the immunosuppression, because the neutrophil count is, it's not about the count, it's within range, but it's just the quality of the neutrophils. It's not active. So we have inactive, we have that are not functional, the neutrophils. So the quality of the neutrophils has changed due to that drug. That's why patients become immunosuppressed. We have three different types of of Cushing syndrome. The most common one, which is the Cushing disease. The most common one is called Cushing syndrome. And that's when we discuss Cushing, we always refer to that one, Cushing syndrome. The other endogenous causes could be the cancer, like lung cancer or cancer to the pancreas. Exogenous, which is most is going to be iatrogenic, which is due to the administration of the steroid. And we said that patients will be on steroid for chronic diseases, like patients with asthma, with autoimmune disease, patients with status post organ transplantation, patients with allergies, chronic diseases, or chronic fibroses. They will take long-term steroid, or they will be on long-term steroid. Manifestations, these are the most prominent and the hallmark of Cushing syndrome: truncal obesity, moon face, which is from the puffiness, the effect of the steroid fluids and glucose and accumulation of fluids and sodium retention, and the buffalo hump and the fluid volume excess and hypertension from the sodium retention. And the patient with Cushing syndrome, they will have, it says unexplained hypokalemia. The only way to, one of the theories behind it is that because of Cushing syndrome, so we have an increased level of steroid, at the same time also will be increased level of aldosterone. Then that would result in fluid retention and sodium retention and potassium excretion. That's why that's one of the theories that will say that the patient will be hypokalemic. We talk about the glucose intolerance, and the patient will become hyperglycemic, and about the increased gluconeogenesis by the liver, which is to make glucose from the protein. So the protein waste, muscle wasting, you will see that patients, they will have protrusion of the abdomen, they have like huge abdomen, they have thin extremities. The thin extremities that can be explained by this protein muscle wasting, but due to the increase and breakdown of tissue protein and increase in urine nitrogen excretion. Musculoskeletal changes. So that's one, you can add the side effect of steroid. Anytime you talk about Cushing syndrome, as if you are reviewing the side effects of the steroids. Muscle mass will decrease, especially in the arms and legs. You see like thin extremities. But the trunk is huge in terms of like, the lipid deposition and the maldistribution of fat, loss of collagen, the collagen, the increased blood vessel fragility. The blood vessels are fragile, and they will cause the patient to have bruises and striae and petechiae. Delayed wound healing, and we explained that because of the immune suppression. The GI symptoms, which is also, I didn't mention that, which is the ulceration of the GI, peptic ulcer disease. Other manifestations pertains to the androgens. The ACTH level can differential diagnose patients with Cushing disease from patients with Cushing syndrome. So this is the steroid fluctuation or cortisol fluctuation in our body in response to the over 24 hours the circadian rhythm. When it's high, usually that's natural. This is natural production of cortisol. Natural will be higher in the 8 a.m. in the morning or 8 a.m. That's the highest, and then midday will drop and then go up again in the in the morning 8 a.m. So that's kind of up and the ups and downs or the fluctuation of the steroid in our body. So the ACTH level in the blood can differentially diagnose patients if they have the pituitary Cushing disease versus the Cushing syndrome. Cushing disease, that would be when the ACTH is elevated, and when it's very low, that reflects the Cushing syndrome. Addison's disease, it's the opposite. So everything we discussed and under the Cushing syndrome will be exactly the opposite to Cushing disease. So all three classes of adrenal corticosteroid are reduced. Cortisol reduced. Mineralocorticoid, which is the aldosterone, also reduced. Androgens also will be reduced. And most commonly, or common etiology, would be the autoimmune response that will destroy the adrenal tissue, and that is idiopathic. We have other causes or etiologies, but the most common one, that's when the tissues are destroyed, the adrenal cortex or tissue is destroyed by the autoimmune response, and that is usually idiopathic disease. And there we have also secondary causes, pituitary tumors, postpartum necrosis, or that affects the pituitary gland. That's called Sheehan syndrome, and that's due to the postpartum. Usually, it results from the hemorrhage and because of the decreased perfusion to the pituitary gland, and that could result in a Addison's disease, decreased perfusion to the pituitary gland postpartum. And then hypophysiectomy. I don't want to recall what is hypophysiectomy from Thursday or Tuesday. See this picture? Just refer to this picture in part 1. You'll find that patients who have developed the adenoma of the pituitary gland, and then this is the surgical procedure to remove the tumor, and that is called hypophysiectomy. So those patients who had underwent this surgical procedure, they may end up with Addison's disease because we are removing part of the gland or removing some of the tissues or removing the whole gland. So it depends on but it's hypophysiectomy surgery. So that could result in Addison's disease. Radiation, secondary causes like and this is one of the most important concepts in endocrinology or the endocrine system when we discuss the steroids. Patients on steroids, we have to taper off the medication when we stop or discontinue the drug. So anytime we stop the drug abruptly without tapering off or being tapered off, that could result in what is called the Addison's disease. It's the there are other names like adrenal insufficiency or adrenal shutdown. You kind of like shut the adrenal glands completely from functioning or become insufficiently functioning. So the insufficient adrenal insufficiency or Addison's disease or adrenal shutdown can result from the abrupt, sudden discontinuation of the steroid therapy, but it has to be tapered off gradually until it's completely discontinued. So that's one of the most important concepts in steroid or therapy with the steroid. Post-op, that could result also as iatrogenic Edison's disease post-op after the surgical removal of the adrenal gland, adrenalectomy, or chemotherapy, or use of anticoagulant, blood thinners. These are some of the manifestations. And the nausea and vomiting in patients with Edison's disease, the mechanism is quite complex, but I just briefly include here under the nausea and vomiting the GI symptoms, because a decreased cortisol that will result in a decreased GFR and gastric acid. That is going to result in decreased BUN, which is blood urea nitrogen excretion. So more of the BUN is going to retain in the blood. Then that results in nausea and weight loss. So the presence of the high level of the BUN, the blood urea nitrogen, that would result in the nausea and vomiting. Complications, and the most serious one would be the circulatory collapse. That's often unresponsive to usual treatment. Patient they are not responding to the usual treatment. Diagnostic studies, the Edisonian crisis, that's the life-threatening, and the treatment will be directed at shock management. And we have to give the patient high doses of cortisol, hydrocortisone, in addition to large volume of normocilline and D5W. So I have a case study, and I will, let me just give you the answers. And if you have a question, we can discuss it next time. So the case study is the first answer. The answer to the first question would be the prednisone therapy, B. The second question, the answer is do not stop taking the medication abruptly, and explain why, right? About the adrenal insufficiency or Edison's disease or adrenal shutdown. That's very important concept. The answer here is Cushing syndrome. The second question on this slide, the answer is A, insulin as needed per routine sliding scale. And I went over this concept, which is when you have a patient on steroid. So the answer is that insulin as needed per routine sliding scale. So dosing or the dosage is based on the blood glucose levels, which is, in other words, we call it insulin sliding scale insulin coverage. The answer for this one would be B, as in boy, 64-year-old female diagnosed with Cushing syndrome. And another case study, the answers for this case study, it's more of a discussion kind of answers. I will post in Blackboard anyways. The last one, just let's finish this one. Get to the presentation right after that. So pheochromocytoma. So we have Cushing syndrome, Edison's disease, and then the pheochromocytoma. Pheochromocytoma, we're not going to talk too much about it because it's a rare disease, and usually it results from the tumor of the adrenal medulla that produces too much of catecholamines, which is the epinephrine and norepinephrine. So, and we know that the catecholamines, they stimulate the alpha and the beta receptors, and they will, that would result in a severe hypertension. So, from the abundant, like excessive amount of epi and norepi, catecholamines, that is going to result in severe hypertension. So, these are the clinical manifestations or signs and symptoms: severe bounding headache, tachycardia with palpitations, profuse sweating, and if undiagnosed, it may lead to diabetes, CMP, which is cardiomyopathy, and death. Most recent research, there's a lot of dietary recommendations like deficiencies of iron or copper, and diet high in certain things that they have that could result in a tumor, and there are some theories behind that, or theoretical discussions about the pheochromocytoma and the dietary recommendations, but it's not quite, I would say, solid in terms of proven by empirical research studies and scholarship and research studies. So let's just focus on the pheochromocytoma, as that it results from the tumor of the adrenal gland, the medulla, and that would result in the excessive production of catecholamines, epinephrine and norepinephrine. 10% of these cases are due to the malignant tumors, and others would be benign tumors, like 90% benign tumors. 10% only could be malignant. Given that the tumor is benign, encapsulated, and affects only one side, unilateral, like one gland, but 10%, malignant tumors. So the patient who developed the hypertension, when they develop the hypertension or in response to the increased production of the catecholamines, the episodes of hypertension, it's only the intermittent hypertension, or the intermittent episodes of hypertension or attacks. It varies in length could last for like few minutes or several hours. And the longer it lasts, then results in more detrimental, complications, especially cardiovascular problems with sustained high blood pressure, malignant high blood pressure, with that severe headache and bounding severe headache and the palpitations and the resultant cardiovascular changes and complications like cardiomyopathy and heart failure. So again, the diagnosis is based on what is called the 24-hour urine collection. So we collect the urine over 24 hours and we send it to the lab, and we the results will give us some indication about if there is any, because what we test in the urine is the metabolites of these catecholamines. So the presence of the catecholamines in the urine could indicate the pheochromocytoma. In addition, also to the vinyl mandelic acid testing. So vinyl mandelic acid testing, which is the VMA. And also, this one also is the 24-hour urine collection for catecholamines and other and other things like VMA, the acid itself, in the urine. And normally supposed to be between 2 to 7. And in patients with pheochromocytoma, it's shown to be present higher than 7. So the increased or high levels of VMA in the urine, 24-hour collected urine, increased or elevated VMA, it indicates the pheochromocytoma. Another testing called the clonidine suppression test, and inform you will cover the clonidine, and clonidine is the antihypertensive medication, drug to treat the hypertension, but also it has other uses or off-label uses. So that's concludes the lecture for today's lecture.